So hello participants of Mumbai WCCICC 2023. My name is Jaroslaw from Medical University of Łódź in Poland, and my today's topic was stress echo anno 2023. So the question whether stress echocardiography has survived the pressure for competing techniques such as computed tomography, perfusion imaging, or cardiovascular magnetic resonance, and is it still a valuable and modern tool in the hand of cardiologists? So principally the concept of assessing our patients during activity or during exercise or during something which mimics exercise is very attractive, because if you think about it, most of your patients will not have predominant symptoms at rest, but in the majority of them, exercise will be something which provokes a real drop in the quality of life, real symptoms, and we need to explain them. So echocardiography, which is probably best suited for real-time assessment of complex physiology, anatomy, and also changes in functioning of the valves, of contractility, is very well suited for this task. So we can use many types of stressors, such as exercise or vasodilatory drugs, dipyridamole, adenosine, or catecholamine stimuli for cardiac contractility, to get insights into ischemia and perhaps more arguably into viability of myocardium. And the pros of echo is that this is widely available. It's a bedside technique. You can have your result right after you complete your study, and it is directly available in most of the departments. However, it has also drawbacks. So stress echo is more difficult to perform on a high level than a standard echo. It takes a dedicated learning curve. Also, some patients with poor quality of acoustic windows will not provide optimal data. And also, it takes a bit of dedication to this more complex stress-based procedures. But it is worth it. So in the year 2023, we are far ahead of the initial situation when we were just thinking regional cardiac contractility abnormalities is the only feature to be addressed in stress echo. Currently, this is something like a dynamic, hemodynamic lab, and we can get insights in many aspects, such as diastolic function, such as valve disease, and also very advanced assessment of segmental and global contractility. In my experience, this is the prime tool to link patient symptoms to a specific cause. Is it ischemia? Is it a worsening of a global function? Or perhaps is it a worsening of pre-existing valvular disease? So first, a proof of diagnosis, usually a definitive proof. And second, very strong prognostic factors. We know that even in patients who have relatively normal epicardial coronary arteries, abnormal stress echo is predicting worse outcomes, more complications. So even if you look at the most modern intracoronary measurements of coronary physiology, stress echo is all the time additive. And finally, our toolbox has expanded markedly, and the current protocol for stress echo is very flexible, and it can include beyond the traditional look at regional contractility, also the measurements, direct measurements of coronary velocity flow reserve, usually in left anterior descending artery, a peak at B lines, or the marker of pulmonary congestion, also at chronotropic reserve, and also at a general cardiac force of the left ventricle. If you put it all together, we can provide a very precise prognostic data and also assess the patient's risk and perhaps indicate the way to optimal treatment, be it revascularization or a choice for medical therapy. So stress echo in 2023 is alive and well. It takes a little bit of dedication and learning curve. However, it's a very proficient tool in experienced cardiac center, and it cannot be replaced for its versatility by any competing technique.